Oh. Okay, I'm audible, Chinmoyda,
Yes, yes,
and my slides are visible.
yes.
Okay. So today we will be talking about the dorsum of hand. Okay. And yes, there are few things which we should know. Uh, Otherwise, it's more of a ligamentous injury, which is much more common when we are talking about the dorsum of hand. But still, there are many things to learn in ultrasound. So first of all, when we are looking at the bony anatomy of the dorsum, so you need to remember the arrangement of, so you need to remember the arrangement of these bones. Happened to my pen. Why isn't it working? Okay, I'll draw it with hand. I don't know, my pen is not working. So you need to remember the arrangement of these bones, right? How they are arranged, right? Not in the proximal and the distal row. You need to know the arrangement of these bones in this axis, okay? So what you can just learn from this slide is, let me erase the, what is happening today? Okay. So what you need to remember here is the arrangement of these bone in this axis, okay? So if briefly you will see, then you will just notice here that when you are seeing this scaphoid, right? Scaphoid is the one which will be having articulation with both the trapezium and the trapezoid, right? Then you have your lunate, capitate, and then it is going to your second finger, like your middle finger. Fine. Now, when you go to your fourth finger, it is, if you draw a line like this, then it is your lunate, then it is your hamate, and then you are going to go to your fourth finger. Once you are going to your fifth, again, if I'm coming from the lateral side, then only I will be able to see the triquetrum. So this arrangement is very important for you to understand. Then only you will be able to find out the carpo-metacarpal joint, the mid-carpal joints very nicely. So today I'll be showing you 2 or 3 of them, and rest you can just practice. Fine. Then what you need to remember is when you're looking at the metacarpal, this is the head. Now, this is the head of the metacarpal. Now, this is the base of the proximal phalanx, right? Then again, this is the base of the proximal phalanx, middle phalanx, base of the distal phalanx, and then distal phalanx. This will be forming your PIP, and this will be forming your DIP. This much bony anatomy should always be there at the back of your mind. Then I'll be teaching you some ligaments today. Okay. One will be your dorsal scapholunate. I think you, Dr. Chinmoy would have already taught you this, but it will be a repetition of that. Then second ligament is your lunotriquetral. Okay. Then one more ligament which you should know is the dorsal lunotriquetral ligament. This also we will be learning. Then we are going to have the radial scaphoid ligament. This also we will be learning today. Just a second, somebody is calling me again and again. Fine. Then these, if you are just seeing, these are our metacarpals, okay? So this something you are seeing here, they are intermetacarpal ligament or transverse metacarpal ligament, one and the same thing. After that, we will be learning the radial collateral ligaments. Okay. So you need to understand the direction of it. And these are all important because they might be the cause for the radial side pain over the metacarpo phalangeal joint. And you might be just thinking of only the pulleys which we have learned, but there is something more to explore. So when you are examining, you need to examine all this, right? So we'll be learning the radial collateral ligament of the fingers. Okay. Then when you come to the thumb, you will be having the ulnar collateral ligament of the thumb, and it is very, very important if you are really seeing the sports, like, you are practicing sports injury medicine also, or I should say, you are just seeing the sports injuries related to the sports. So if somebody is coming to you, these are all very important, these ligaments, because they encounter all this ligamentous injuries, right? So here it is very important for you to understand that this ligament will be present over your metacarpophalangeal joint. Okay. And on the top of this ligament, you are going to have the aponeurosis of adductor pollicis. Adductor pollicis we have seen when I showed you the thumb, when I showed you the palmar aspect of the hand, right? This is the one which basically attaches to the, as you can see, the base of your proximal phalanx. So it is coming from this ulnar side and it just attaches on the medial side of the proximal phalanx, right? And this is very, very important. So we will be learning this also. And then finally, what you need to remember here is this extensor digitorum, okay? So this extensor digitorum, as you can see that it has got one central tendon, okay? And then these are the two slips of it, right? So this central tendon is the one which will be attaching at the base of the middle phalanx. Fine. And then this lateral tendons, they will be combining here. And now they will be attaching to the base of the distal phalanx. So it's just more or less like a leaf. Why is it important for you to understand is, supposedly you are looking for a tendon in this area. You are scanning and you are seeing. You will not see anything over this bone. Okay. So you need to tilt your probe towards the lateral side. That is the reason you need to know this, because sometimes what happens, any patient will come to you that they have got an injury to this distal phalanx, and maybe if you are the one who is evaluating this patient, so you can put your probe and you can just see whether there is any kind of avulsion injury of the bone along with the attachment of this tendon. So that is the reason you need to find out the small things when it comes to the dorsum of your hand, right? So again, I'm repeating because this is something we do not study in most of the courses, right? So first is the arrangement of these bones, which you should know along with the metacarpals, because I usually scan from the metacarpal and then I go towards the carpal bones. That is the first thing. And then these bones and the joint name, you should know, right? Then you should know few ligaments. This is radial scaphoid. This is radio-lunotriquetral. This is your scapholunate, and then you have your lunotriquetral ligament, right? And this also you need to know, transverse metacarpal ligament, okay? Then these are the radial collateral ligament of the fingers. Then you have ligament, it is just with the name. It is just holding these two bones in place and just maintaining the stability of these two joints. And so if there is a problem, there will be an instability of these joints. Or if there is just an initial injury, which we'll be learning in the subsequent slides. So do not think that it is not important to learn this ligament. It is equally important. Every ligament, whichever I have told you, because I have just selected the one which are commonly injured rather than teaching you all the ligaments, and then, it will just become a mess because there are so many ligaments to learn, from radius to all the carpal bones, between the carpal bones, and there are lots to learn, but I have just picked up the few ones. Then this ulnar collateral ligament of the thumb is very, very important. And what is the point which you need to remember is this aponeurosis of your adductor pollicis. Okay. Then you need to remember that this extensor digitorum, once it is going, over this proximal phalanx. Okay. So after that, there is a splitting up of it, right? The tendon, and it just gives two lateral slips and it gives one slip. So whatever is there in the center becomes the central tendon, and on the side, it becomes the lateral slips. So you should know how to identify these two, and of course, their insertion as well. Okay. And one more thing is the sagittal bands. Okay. This is also very important because if there is a problem with it, we are going to call it as boxer's knuckle. Okay. So what usually happens here, you are seeing that it is passing over a joint, right? So there should be someone should be holding this tendon over this head. Okay. So if you see these pictures, they are the bands. Okay. They will be holding this tendon in place. And if you do not have, I should say, if you have a problem with that, these tendon will not be going exactly over it. Okay. If all of you can flex, you will see that there are slips which you are able to see over your knuckles. Supposedly over the knuckles, you are not seeing the slip and you are seeing the slips here. So it means there is a problem in the sagittal bands, right? So these are sagittal bands that also we will be learning. So only this much in the anatomy. Okay. And if you have any doubts, you can ask me, or I will just show you the sono anatomy. But before that, quickly, we will be revising the dorsal compartments because I will be showing you everything from the distal end of the radius. So there'll be a revision of the dorsal compartment. But before that, if you have any question, please ask me. No questions?
What do you mean by the slips, madam? I didn't understand that.
Slips is the splitting up of the tendon fibers. Means, you know, your tendon will split up. So some fibers will be forming the lateral slips and some will be remaining in the center. So what is remaining in the center is the central tendon. What it is going from the lateral side, we call it as lateral slip. Sophisticated. But it is nothing, but it is just the tendon fibers. Okay. And one thing more, when I'm revising, I please request all of you to just answer. This is just to see whether whatever we have taught you, whether you remember that or not. So quick revision of 10 minutes, and then I will come to today's demonstration. And I expect all of you will answer. At least try, even if you are wrong, there is nothing, no harm in that, right? So I'm examining in the supine posture, okay, because I think the volunteer is also comfortable and I am also comfortable, right? You can scan the patient in the sitting posture. And since we are just learning the dorsum, since we are learning the dorsum of the hand, okay, so how the hand has to be. So he's lying down in a supine posture, shoulder is abducted, elbow is extended, forearm pronated, and palm resting on the table. Okay, this is the side table. So it's resting there. I'm using a high frequency probe of 20 megahertz frequency because we need to see something very, very superficial, very, very superficial today. Okay, approximately at a depth of 1 centimeter. So I have set the depth also at 1 centimeter. And I usually do not call it, as I have already told you, and I was showing you the the palmar aspect, that I do not call it as radial and the ulnar side. Either the means I do not call it as lateral and the medial side. I prefer calling it as radial side or the ulnar side, right? Thumb side or the little finger side, so that we get a 3D picture the moment I'm going to tell you I have kept my probe like that. Fine. Okay, just give me a second. I think the logo of the machine is not visible, which is very important for us. So that's why I'm adjusting it. Yeah, this will be fine. Because we should know where exactly our aspect marker is, which we can find out only with the logo of the machine. Not logo, I should say. They have written the machine name. Fine. So now I'll be putting my probe with the aspect marker towards the little finger side. Okay. And it is in short axis to the distal end of the radius. Okay, let me decrease it. Now, who can tell me what all structures we are seeing? Anybody? So that from there, if I'm moving, you know what exactly I'm showing you. Anybody can comment on this picture? Anyone?
Lister tubercle and the extensor compartments.
This is the lister tubercle. Sure.
Yes.
Okay, great. So lister tubercle. Okay, extensor compartment. Could you please tell me what
The
all you are seeing?
second,
Okay, which
second,
side? If this is your ulnar side, if this is your radial side, which side to the lister tubercle is the second compartment?
to the radial side.
Very good. To the radial side is the second compartment. Uh, do you remember the name of the tendons?
The second is the extensor carpi brevis and longus.
Very good. Superb. Okay, so this is ECRB and the other one is ECRN. Okay, what is this one?
The third extensor compartment, which
Yes.
which have the extensor pollicis longus.
What is this?
The fourth extensor compartment, which has the extensor digotorium and I don't know the other name, the small extensor.
I've given you the hint. Indices, okay, or indices, whatever you want to say. Fine. Okay, if this much you know, then it becomes easy for us to go from there. Okay, very good. So it seems you are really reading. So if this is our lister tubercle, right? The one which is in the center, which she has explained beautifully. I think probe is not visible. I think it is fine now. Okay. So if this is the lister tubercle, right? Now from the lister tubercle, if I'm coming down, which bone I should see? What is this bone which I'm seeing? This bone which is here? Anyone?
Radius?
No,
Distal
radius was here.
Ah,
Lister tubercle is on radius. From the radius, once I
Yeah.
have slided down, this is the joint. And once I have crossed the joint, one bone will come. So what is this bone?
scaphoid.
Yes,
Scaphoid.
this is scaphoid. Very good. So from the scaphoid, if I'm going towards the little finger side, what I should see? The center?
Lunate.
Very good. And what is the third bone which you are seeing? Starts with
Triquetrum.
T. Yes, it is triquetrum. Very good. So it is scaphoid. You remember three bones? Once you have slided from the lister tubercle, and these three bones are scaphoid, lunate, and triquetrum if you're going from the radial to the ulnar side. Okay. So if this much you know, we are going back now to today's class. Okay. So the first ligament which we will be seeing is going to be our lunotriquetral, right? So if this is a radius, okay, supposedly you are a beginner, you really don't know how exactly you are supposed to pivot the ulnar end of the transducer. So what you can do is, now you know this much, that if this is the So now you know this much, that this is the lister tubercle, okay? And from the lister tubercle, if you are going down, this is your scaphoid, this is your lunate in the center, okay? Scaphoid, lunate, and triquetrum, S, L, T, okay? Now, either you can keep one of your finger at the center of the probe like this. So means from the radius, you are supposed to rotate your probe in this manner. Then only you will be able to see the radiolunotriquetral ligament. Okay. So again, back to the lister tubercle. I'm not telling the probe position again and again, because when I say home page is lister tubercle for the dorsum of the hand. And when I say home page view, that is a listed tubercle view. Our probe will be in short axis to the distal end of the radius with the aspect marker towards the little finger side. Okay. So this is how I usually keep my probe. Fine. So from the, we'll go back to the listed tubercle and I will go in a convex view now. Okay. So if this is my listed tubercle, right? Fine. We are able to see the compartment 3, compartment 4 very nicely. Now what I'm going to do is I'll keep tilting the ulnar end of my probe. Okay. So I'll keep tilting the ulnar end of my probe until I see the lunate. That was the reason of showing you everything from here. So I'm just tilting. So now I know lunate has started coming up. Okay. So this is the lunate which has started coming up. Now I'll slide my probe little more. And I will just try to, at this end, I will try to just do a little bit of toggling of my probe so that I will be aligning my probe to the ligament which I want to see. So now my probe position is this. Okay. So what we are seeing, this portion is our radius. This is our lunate. This is our triquetrum. So what ligament we are seeing from here going till here is our radiodunotriquetral ligament. Okay. So nothing you have to do. Put it over the listed tubercle, right? Identify that this is the radius. You keep the radial side fixed and start moving the ulnar side. How long you will move until you start seeing the lunate, and then just little bit of toggling of the probe. And the easiest way is from the listed tubercle, identify the scaphoid, lunate, keep one of your finger there. Okay. And then go back again to the listed tubercle. Okay. And then fix your radial side, and where you have kept your finger, just rotate it to that. Then also you'll be getting it like this. So whatever technique you want to follow, it is up to you. The easiest one when you are learning ultrasound for the first time is to keep your finger. Okay. And that will be the best one. Okay. So now we will be going to the radial. Okay, before that, here itself, I will show you something else. But this I think Chinmoyda has shown you. So he has shown you, the scapholunate ligament. Anyone? No one wants to answer. Very sad. Dr. Arindam, have you seen this? Scapholunate ligament.
Can you repeat, please? I seem to be lost a bit there.
Lost? Where? Today's Saturday night mood.
So I know at least you explained nicely. I'll catch up, please. You are so patient with us. Sorry.
No problem, no problem. So you want me to repeat this?
Yes,
Again?
yes.
Okay, so now don't get lost, okay? Be here with me.
I promise.
Okay, so we will go back to the listed tubercle. So that's the listed tubercle. Fine?
Yeah.
Where is the listed tubercle? This is the listed tubercle. How to remember the listed tubercle? It is just like 2 slides, okay? And you will be having a projection here. Fine? So that is your listed tubercle. From the listed tubercle, I'll just see, okay, this is my radius. Okay, till here is my radius. So I know this is the radius. I'll just bring it little here so that I'm able to see the 4th compartment. And this bone which has come is your ulna. Don't think this is your lunate. Once you have kept your probe like that, fine. Now you keep this radial end fixed. Radial end means which is towards the thumb side, this end. Okay, fixed. And then you start rotating it. Rotate, 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 rotate. Now I know lunate has started coming up. So this is the ligament basically, which is going. So I will just try to angulate my probe in such a manner that I am able to see it nicely. That's all. From this side, it is just the toggling, nothing else. Now you will be able to see it nicely. Are you able to see it?
I can see below the compartment, there's a top
Yes,
compartment.
yes. That only.
Okay.
Okay,
Wonderful. Thank you. Okay.
okay, fine. So
Which
this we have finished.
which compartment is that above the ligament, doctor?
Fourth compartment.
Fourth compartment.
See, how to identify fourth compartment. See, it is the biggest compartment. Okay, see, such a big compartment, isn't it? This one. This is the fourth compartment. Now, what you are seeing here is the sixth compartment. So I will freeze it here so that this confusion should not be there. Okay. So see, the fourth compartment is the most easiest compartment to identify. Why? So if you see all the tendons, they are all small, right? But this is such a huge one. Fine. And this tendon will be having small slips of the tendons within it. See, you are having the slips here, right? Compartment fifth is also very easy to identify. How? This is your ulna. This is the radius ending up. Fine. Now, this is your DRUJ, dorsal aspect. Fine. Now, this tendon, what you are seeing is your extensor digiti minimi. This tendon, you should always look on the top of this joint, right? So you will never go wrong, because if somebody sends you a patient of rheumatoid arthritis, early stage, this is the joint which you should evaluate. And if there is an erosion of this joint, right, if there is a capsular involvement, because just outside this joint is your extensor digiti minimi tendon, which is sitting there. So you might be having an involvement of this tendon as well. Is that clear? Now, fourth compartment.
Yes, doctor. Thank you.
Thank you. Fine. So we have finished that. Now we will go to, okay, I'll just show you the dorsal, this scapholunate also once again. Let it be a revision for you. So from the listed tubercle, now what you need to, what did we learn from the Palmer aspect? That if I am at the, radio-ulnar joint. So this is ulna, this is radius. If I am at this joint and I'm going to move down, it should be the lunate which should come. Okay, this we have learned in the Palmer aspect. The same holds true for the dorsal aspect also.
Lunate is appearing there.
The same holds true for the dorsal aspect also. So this is our joint. Okay. Now from the joint, if I'm going to move, one mountain will appear. Okay. This mountain has to be lunate. So see, I'm moving down. Okay.
Yes.
So this bone has come. This is my lunate, right? But do remember, if you are moving from the lister tubercle, okay, the bone which you are going to get here is your scaphoid, not lunate, right? So if you are moving from the lister tubercle, you will be seeing the scaphoid here. But if you are moving from the radio-ulnar joint, it is the lunate, not the scaphoid. So if you want to see the lunate, you have to slide your probe towards the medial side, right? Then only you will be able to see the lunate. And then if you will slide your probe more, your triquetrum will come. Fine. Now, if this is my scaphoid and that is my lunate, I'll just try to angulate and get back to that fibrillar pattern. Okay. So this fibrillar pattern which you are seeing between the lunate and the scaphoid, that will be your dorsal scapholunate ligament. Okay. This is also very important for you to know. And I thought you have already learned this. Now we'll learn the radial scaphoid lunate, radial scaphoid ligament. Very simple, very easy. What you need to do, you already know this is the radial border, right? This is the radius. So what you need to do is you just put your probe there. Okay. So you know that what you are looking here is the radius. So the next bone which should be coming, it should be your scaphoid, right? And I'm putting my probe in the craniocaudal direction now. So what I'm going to do is, I will just angulate my probe in this manner. Means I am going to see it like my footprint will be just over, like I'm seeing it from the Palmer aspect, okay, a little bit more, so that I will be able to see this ligament very nicely. So what you are seeing here, that is your radius, this is your scaphoid, and this one is your ligament. Which ligament? Radial scaphoid ligament. Okay, fine. So you have to see the radius, you have to see the scaphoid, and this will be the ligament which you should know. Fine. And how to look for the joints, right? Because they are very important, especially your hand ultrasound is very important if you really want, if you're just seeing so many rheumatoid arthritis patient, okay? It can be a boon. Now, do not start from here because you might get confused. So always start from your metacarpal, right? And then you go to your carpo-metacarpal joint, and ultimately you will be going to midcarpal and then the radiocarpal. Fine. So what we are going to do is, so this obviously, this bone which I'm palpating, this will be my metacarpal. Okay. So this metacarpal is finishing almost till here. So, and this radius is almost finishing here. Means in this portion, I am going to have my scaphoid and my trapezium. So if it is a joint between the radius and the scaphoid, this will be my radiocarpal joint. If it is in between the trapezium, the scaphoid and the trapezium, this will be my midcarpal joint. If it is between my trapezium and the metacarpal, okay, so this will be my carpo-metacarpal joint. Fine. And from the metacarpal, if I'll go up, that will be my metacarpophalangeal joint. Fine. This, it should be there just like that in your mind, right? So what we are doing, we are just starting from our metacarpal. Now here the aspect marker is towards the patient's head, okay? So what you are seeing, this you should never forget, okay? So what we are seeing the base of the metacarpal, right? And if I'll go up, I will be able to see two bones here. One is this bone and one is this bone. Fine. So if I'm seeing these two bones, I will just freeze it here for you. Okay. Means if this was my metacarpal, this is a carpal bone 2, this is a carpal bone 1, right? So what should be the name of this joint? Who can tell me? Anybody?
Carbo-metacarpal joint.
Very good. This is carpo-metacarpal joint because this is a carpal bone and it is a metacarpal. So you have to just combine these two. Okay. Carpo-metacarpal. What you have taken? You have taken the C of this and MC of this, and it is a joint. So it becomes carpo-metacarpal joint. Now, this is one carpal bone and this is one carpal bone. So this bone is your trapezium. This is your scaphoid, right? Now, what should be the name of the joint between these two carpal bones? Anybody?
Mid-carpal joint.
Mid-carpal joint. Very good. So it becomes the mid-carpal joint. Now, this is a carpal bone. Okay, this is also a carpal bone and it is in the center. That's how you have to remember. Okay, so from there, if I'm going up, so we will just come back again to it. So this was our metacarpal. From there, I have slided down. I could see, you know, the change in the shape of these two bones. One is this, one is this. So obviously now I know this is the carpo-metacarpal joint. And from there, if I am going up, I know that I've crossed two bones. One was here. What happened? One was here, one was here. So let me increase the depth for you. Okay, I think this will be fine. Now from the scaphoid, if I'm going to go up, okay. So you will see one bone here, and if I'll slide more up, again, we will come back to this. So means this is one bone and this is another one, right? So this is your scaphoid and this becomes your radius. So what should be the name of this joint?
Radiocarpal joint.
Radiocarpal joint. Fine. So this is how you should keep on appreciating and you should keep on going up. And that is how every joint you should identify. Okay. Then we will come to the radial, I should say, the radial ligament of the fingers. Okay. This is also important. Okay. Before that, we will complete the other thing, like the how the other joints will look like, so that finishes our joint section. So we have seen here, okay. Okay, I will show you from here. Again, my probe is in the longitudinal axis of this carpal bones, metacarpal, not carpal, with the aspect marker towards the volunteer. Okay, fine. So that is an hyperechoic line which I am seeing. Okay, so I will slide it down. So if I'm sliding it down, I use jelly because this. And if you have an hockey stick probe, that is the best probe. Okay, I don't have, so I usually manage with this probe only. Now you will be seeing something like this, right? Let me go back. So we are now seeing something like this. So what it has to be, because we are now coming distally. So means this is the metacarpal head, okay? And this is the proximal phalanx, which is starting up. And you can see a beautiful tendon which is going over it, right? So they are your extensor tendon. This is our metacarpophalangeal joint. And what you are seeing here, that is the connective tissue, okay? And what black thing you are able to see here, that is your cartilage. Fine. So now we are going from the metacarpal to the DIPs. Now, if I am moving from here, okay, so now I am seeing the proximal phalanx, okay, you are able to see the tendon also, because I'm just using the gel stand off to show you, okay. So now you will be able to see something like this here. I will reduce the depth because we don't need this much of depth. Okay. So now I'm seeing one bone here and the another bone here. Okay, so we have moved now. Initially, what did we do? It was the radius. Then we came to the scaphoid. Then we have seen the trapezium. Then the metacarpal. Now from the metacarpal, now we are going towards the proximal phalanx. Then we are going to have our middle phalanx. And then we are going to have our distal phalanx, right? So between the radius and the scaphoid, it was the radiocarpal joint. Scaphoid and the trapezium, it was the mid-carpal joint. Between the metacarpal and the proximal phalanx, metacarpophalangeal joint. Okay. So this much we have seen. Now where we are going? We are going to the proximal phalanx and the middle phalanx. So this becomes our PIP. Okay. And this was our metacarpophalangeal joint. You can see the tendon also very nicely. Okay. Now I have come to the proximal phalanx, finish the proximal phalanx. Now the center is my PIP. This is what I have shown you. So if I'll go more, I will be just seeing the middle phalanx. Okay. And if I will slide my probe more, I will be able to see the DIP. Okay. I hope this much is clear to all of you because this is very important, right? All the joints you should know. Radiocarpal, and if any one of you is preparing for RMSK, this, I got a question from this. There was only a picture and we were supposed to find out which joint are we looking at. Okay. So you were supposed to label it that time in that picture itself, what joint you are seeing. So if that's the reason, you should know the curvature of every bone, how it looks like. Okay. So I'll just tell you one thing, like how exactly you should, your eye should be getting accustomed to the USG picture. This is very, very important. So supposedly, I will give you a picture like this, right? Now, if I'm giving you a picture like this, anybody can tell me that this is DIP. I'm seeing the nail bud here, the nails here, right? So you will never go wrong. Fine. Now, if I'm moving my probe to the metacarpophalangeal, obviously, you will know that the head will have a dip and then it is rounded one. This is proximal phalanx. Again, you will never go wrong. And if there are two equal bones, almost like this. So this is going to be the proximal interphalangeal joint. So this picture should always be there at the back of your mind. How exactly the metacarpophalangeal joint will look, how exactly the PIP will look, how exactly the DIP will look. So you can very well distinguish between them if you really know the basics very well. So that was about the joints. Now we will learn the radial collateral ligament of the fingers. They say ulnar collateral ligament is little difficult of the fingers to find out. It is because of the problem with the probe. It is not possible to put them apart so much that you will be able to see it. But the radial is easily accessible, right? So what you are supposed to do? Where is this radial collateral ligament present? It is present at the junction between your metacarpophalangeal joint, right? And it goes in an oblique manner like this. Fine. So let me now fix it here. And it goes into an oblique manner. So if it is going into an oblique manner, how are you supposed to orient your probe? Now you know your metacarpophalangeal joint, right? And then if I'm sliding my probe in this manner, right? I'm just keeping it in such a manner. Now you see, okay, let me do a little bit of more toggling. And I'll freeze it here, right? So once I am doing that, how I have done it? Nothing. I know where is the metacarpophalangeal joint. By this time, by scanning, we have learned, right? And I have just tilted my probe, I should say the other end exactly towards the table. Okay. So now what you are seeing here, that is your radial, because which side is this? The radial side, radial collateral ligament of fingers. Which finger? It is the index finger we have scanned. Till this much, is it clear to everyone?
And please repeat one more time.
Please repeat. And what you are seeing on the top, okay? So they are your tendons from the dorsal interosseous and the lumbrical. They will also be coming on the top of it because they have to come from the palmar aspect and then they attaches here. So what small, thin things which you are seeing on the top, they are the tendons of that. Fine. So how is the hand position? We have not changed, right? So what we have done, we know this is our metacarpal head, right? So this is proximal phalanx. Somewhere here should be the junction. And I will keep it in such a manner that this aspect marker is facing the ceiling and the caudal end is facing my table. That's all. Keep it like that. In one go itself, you will be able to get it. Okay, and then just little bit of toggling is required just to align your probe in line with this tendons. That's all you have to do. Is it fine now? Are you able to appreciate?
Yes, ma'am.
Fine. See the fibrillar pattern so nicely it is seen. Got it? And now you can toggle and you can see the whole of this fibrillar pattern. So that was about the fingers. Now we'll go to the thumb. Now, thumb, what you have to do, we will be learning the ulnar collateral ligament. So this is the ulnar aspect. This is the gap. Now you put your probe in this gap. Again, you have to orient it such a manner that the cranial end is facing, your ceiling, caudal end is towards the table. Okay, it is the same arrangement. But yes, if you have a hockey stick probe, it is much easier. Otherwise, you have to little bit of manipulation is required with your probe if you are using a probe, means, the footprint is too big like how I am having, but still you can make it up. But yes, interventions usually becomes difficult when you are having this bigger footprint probes. So I'll just ask him to flex so that this becomes taut. And again, I will just put my probe in the, I should say, the craniocaudal direction, because I will be looking at the longitudinal axis of the tendon. So this cranial side is towards him and the caudal is towards me. Cranial is towards the volunteer, right, the forearm, and the caudal is towards me. And then I will orient it and I will make it cranial towards the roof and the caudal end towards the floor. Okay. So I'm just keeping it like this. Fine. So we have started seeing the ligament. This is the ligament. But yes, now we will just little bit of toggling is required. So we will be able to see it nicely. Okay, I will freeze it here. So this is the ligament which you are seeing. I don't know, my pen is not working and with the fingers, I think it is becoming too bad. Okay. So this was the cranial side and this was the caudal side. So this needs to be the proximal phalanx and this needs to be the metacarpal. This is your ulnar collateral ligament of the thumb. And on the top, what you are seeing is the aponeurosis of the adductor pollicis, okay, which attaches itself to the base of the proximal phalanx. Fine. So that is the ulnar aspect of the ulnar collateral ligament of the thumb. Now we'll quickly see the sagittal bands. So for that, now we will be changing the position. I will be asking him to hold this bottle. That's all. ऐसे मोड़ लो. हाँ, जेल में. Mold. Okay. So these are your knuckles, right? And you need to look for this tendon in the short axis, right? That is the preferable one, not the longitudinal axis. Fine. So what you are going to do, we know these are the metacarpal heads. So you put your probe in short axis over them. I will apply lots of jelly because it is so much bony. Okay. So you just put your probe in the short axis over this head and you try to look for this tendinous thing. Okay. I will freeze it here. So what you are seeing here is the tendon. These are the sagittal bands. What you are seeing here is the capsule, okay, of your metacarpophalangeal joint. This is the metacarpal head and this black line is the cartilage. So this position is also very good to assess the metacarpal cartilage because you do have a grading of the cartilage degeneration when it comes to your metacarpal head, which I'll be discussing. Okay, and this is also very important, like how it is important for us in the knee. I think knee we have not covered. So when we will be teaching you knee, that time I'll be showing you about the cartilage of the knee also. So this position you should always remember. Why? Because this should always be over the center. If you are not able to see it here, supposedly you are seeing it somewhere here, or you are seeing it somewhere here, then it is problematic. It is not the normal one. So do remember it should always be on the top. So this is your tendon in the short axis and the sides, what you are seeing, they are the sagittal bands. This is not the sagittal band, that is the capsule. So now we will see the tendon in the longitudinal axis. For that also, I will be using the gel standoff. So again, same back to our home page view, right? Now what I'm going to do is, I will just keep it over the metacarpophalangeal joint, okay? So you should be, once you are keeping it here, right? You should be able to see the Mali, एक बार उधर से आना. I will catch hold of it and I will ask my assistant to freeze it. Freeze कर दे. Freeze. So this is a bone, right? And we are able to see this tendon. So take home message is, if you really want to see this tendon, you should have a very higher end machine. Otherwise, you will not be able to see. Okay. I used to find it very difficult when I used to scan with my Sorte machine. Okay. Because this fibrillar pattern, I was not able to appreciate, because right now I'm working at a depth of 0.04. Okay. So you can imagine like how difficult it will be if we are not having a good machine, right, to visualize these small injuries. Then once you follow this, okay, once you follow this tendon, so where we have come to the PIP, okay. So here you will be, wait, I'll ask him to freeze karna. So this is the central tendon which is coming and getting inserted over the middle phalanx. Okay, that was the whole tendon which we have seen traveling over the metacarpophalangeal joint. And then now we are seeing the middle phalanx, because we know this is PIP and we know the central tendon attaches itself on the, I should say, the middle phalanx, right? Now, if you want to see the attachment, okay, of the lateral slips, then we will go to our DIP, right? So once we are over the उंगली को नीचे की तरफ बस ऐसे ही रख, ऐसे ही रख. प्लीज करना माली. So now what you are seeing here, okay, because they have combined almost here at the proximal end of it, and then it has got attached on the base of the distal phalanx, right? So this is DIP, that is the nail which we are seeing. So you need to evaluate this tendon at 3 important points. One is at the metacarpal head. Then you need to evaluate it at the junction of, where the central tendon is getting inserted on the middle phalanx, and then you evaluate it here. So if you have a problem with this, suppose, which I will be showing you, then this tendon, you should be seeing it something like this. Supposedly you're not able to see the tendon here. It means some problem has occurred. These are for these tendons. Ligaments, lunotricutal, radial scaphoid, and scapholunate and lunotricutal ligaments. You should know how to identify. You should know how to identify the radial collateral ligament and the ulnar collateral ligament of the thumb. So this much at least you should really scan when it comes to the dorsum of the hand, though there are many things, and of course the joints which I have shown you. So go back, put your, I should say, the skeleton of the hand, right, along with your forearm bones. And then when you are scanning, just try to remember the shape. Like, I'll just tell you, if we are seeing the scaphoid has got this kind of a shape. When you go to lunate is something like this. And when you go to tricutum, it will be again something like, like this. So this shape, you should remember how exactly they look like from the, the top portion. So if you will know how they really look like, then you will never go wrong. Metacarpal head will always be like this. Okay. Then it will be articulating with the phalanx. So this you should know. When you are looking at the DIP, the dorsal one, right, you will be having the nail, which will be just hyperechoic to you. And in between, if you are seeing two lines like this, then definitely you are looking at the PIP. Okay. So these bony landmarks are very important, especially in the dorsum of the hand. So that's all for the demonstration. Now, if you have any other questions, in the demonstration part, you can ask me, or I will just go to the pathology. Nothing? Okay. So pathology is not much. Quickly, I'll just go through it. So this is important because we have now learned how exactly the tendon is getting attached on the distal phalanx. So if there is a problem, okay. So if there is a problem, what happened? We are going to call, thing is happening. So we are going to call it as mallet finger, baseball finger, or cricket finger. What exactly is this? So here you are going to have I don't know why it has become so sensitive that it is not taking up my. Fine. So if you're having an injury to the distal insertion, okay, when it is I should say the lateral slips which are combining and then getting inserted on the distal phalanx. So if there is an injury to that, we are going to call it as mallet finger, baseball finger, or cricket finger. Fine. So how it is gonna, if you have identified, sometimes what happens is this tendon will be just taking a bone along with it, right? And they will be not able to extend the DIP. Okay, so it will be like this. So that is the picture. So if you have an injury to this, so if you have an injury, see that is your lateral strips combining and getting attached, right? So what will happen? This extensor is not working, but obviously flexor digitorum profundus will be causing the flexion of the DIP. Your extensors are not working, so finger will be in a flexed position. Your DIP will be in a flexed position. And if you will see, we have seen a very thin layer, but here you see it is full of all hematomas, right? This is the normal one. So you are not able to see any of the tendon fibers there. And you have a splint, which they can wear, and they can other than following the conservative treatment, okay, which I'm not repeating, but these kind of splints they come, so you can ask the patient to wear it, okay. And second, I was telling you that you can have even the avulsion injury, okay, of the bone itself, right? So that is the reason you should know how exactly the PIPs and the DIPs will look like under ultrasound. So this was our. So this, we have seen that this was our DIP and this is your middle phalanx. But here you see this bone, it has got taken off from there and it has gone to the middle phalanx. And this is how it will look like under X-ray. Fine. And here also you have, I should say, your flexor extensor tendon, which has got inserted on the distal phalanx, has got, has come out from its insertion. So if you have a problem with the sagittal bands, like usually it happens in a boxer, okay? And even if you're going to gym and you are doing lots of this, boxing, kickboxing, then also you are much more prone for the development of injuries which are related to the sagittal band. So these patients will be having the pain and tenderness over the knuckles. There'll be a swelling. They will say there'll be a movement. There'll be a pain when they're just moving their knuckles, right? And sometimes the popping sound will also be there. Okay, why? Because these tendons are exactly going over this head, right? So whenever I'll be doing the flexion and the extension, so there might be some kind of a popping of the tendon out of its place. So how exactly it will look like under ultrasound? So this is what we have seen, right? It should always be sitting over the head. But here we are having some kind of problem on the sides, right? Some kind of problem only on this side, right? So, but still the tendon is maintaining its stability, right? In some cases, you will be able to see something like this. So this is the head and it should be somewhere here, but it is not at the center, but it is just tilted towards this side, right? Do remember one thing, that it is like a tenting, okay? So what will happen if there is a problem in this limb of this tent, then this center point will be going towards the normal side. So towards the normal side will never be the side which will be injured. So instead, like this is the, the center where you should be seeing the tendon, but rather than here, okay, so I will draw it like this. So rather than on the center, you are seeing this somewhere here. Means that is the normal side and the other side would have got injured. Sometimes what happens, you will be able to see this tendon almost there, neither this side nor this side. So this is basically a dislocated one. Okay. This one is subluxation because the normal side has pulled it. And again, when you will extend it, it will go back to its position. So that is subluxation. And usually they say that we can just immobilize in an extension splint for 4 to 6 weeks. But if you go back and read the literature, it says even the acute and the chronic cases, okay, they at later part of their life might require the surgery. Then this is important, okay? And this was again my RMSK question. So this question is very close to my heart. Sterner's lesions came to me during my exam, okay? So Skyer's thumb, gamekeeper's thumb, and Sterner's lesion, okay? So now in this also, it is the same ligament which is getting torn. But if it is an acute injury, we are going to call it as Skyer's thumb. If it is a chronic injury, okay, because he will say, no, I usually have a problem here. What all problems will be there, we'll discuss for a longer time. It is gamekeeper's thumb. Some says they are not different. They are one and the same thing. Okay. Now this is very peculiar. So what happens if you have a problem with the ulnar collateral ligament, and what is the aponeurosis of the adductor pollicis, which is just going over it? Supposedly this is the one which has got, which has come in between the two rupture end, then we are going to call it as Sterner's lesion. So Sterner lesions, like the question came for me, is what exactly? Very simple one, but still you should know for that what exactly is Sterner's lesion. That Sterner lesions, which it came as, which aponeurosis of which of the following muscle will get interposed to call it as a Sterner lesions. So question was very simple, but you should know what exactly it is. Okay. So now, how exactly the injury is happening? Supposedly, you can see here, if I am landing like this, okay, in this manner, from here, this position, whole of my pressure will be going to the ulnar collateral ligament, right? So much of valgus stress to the thumb in your abduction and extension, right? Like you play hockey, basketball player. So this is more commonly related to the sports injury, right? So here, these patients will have the joint laxity. They can have pain, they can have weakness, and because it is just over the metacarpophalangeal joint, so they can have even the arthritis in the metacarpophalangeal joint. So this is again a simple version of learning it, that these patients will be having pain where? At the base of the thumb. Usually, where did we put a probe? In the web space. So exactly there only they will be saying. They can have a swelling of their thumb. They can have a weakness of grasping, okay? And it will be very much tender to touch along this side, because this is the side where it is located, right? Sometimes you can have a, bluish or blackish discoloration, or they will say wherever side you will move the thumb, they will be having a pain. Now, this slide is very important. Okay. What exactly are the grades of its tear? You can read it more in this journal, okay, from where I have taken this picture. So this is your adductor pollicis aponeurosis, okay, and beneath that is your ligament, right? So you can have a ligament tear near its insertion. You can have a tear, intrasubstance tear, or you can have a full thickness tear, right? Or you can have a full thickness tear. You can have a full thickness tear, but here your adductor pollicis will be just going in between these two, right? So this near the distal insertion, this is mid substance, this is full thickness. Okay, still adductor pollicis is there in its own place. Okay, but here this has retracted and it has gone inside. Okay, this is what are the grades of it. So this is very important. This is not only for this lesion alone, but you just remember it for all you can take a screenshot when you're just listening to the recording. You can have an acute sprain. You can have a partial thickness tear. You can have a full thickness tear, or you can have a chronic sprain. So these are the sonographic features of it, which you can just go back and concentrate more on it. Okay. So I will be just showing you some of the USG pictures so that you know what exactly we are talking about. So as you can see, this is our ultrasound. Okay. Now there is one portion of it and there is a gap, right? Means the first one which we have seen. Okay. So you put the color Doppler, this side will be taking up the color Doppler, right? But if you see the, the muscle, the aponeurosis, not the muscle, aponeurosis of the adductor pollicis, then it's still intact. But if you will see this picture, this is one portion and that is the retracted one, okay, which has gone, means it's a full thickness tear, completely retracted portion. But here you are seeing that it is dipping here, right? Your adductor pollicis. So this becomes your sternal lesions. Supposedly, I'll keep this picture in your exam, maybe. So you should know that we are talking about the sternal lesions. Sternal lesions is only when your adductor pollicis is getting in, okay? Otherwise, it is just your UCL, the ligamentous injury. Fine. Now, this is also very important whenever you are evaluating, okay? And do read your OMERACT, I should say a very good article. And these are basically the guidelines which we follow when we examine your metacarpals and all. Fine. Now, this is very important. How exactly you will find out whether there is synovial atrophy, synovial hypertrophy or not. This is very important. And this is, I should say, I shouldn't have included it here. We should have taught you in the basics of ultrasound because this is very important. How to find out the synovial hypertrophy grades, right? So if you see, this is how we have seen the joint, right? The connective tissue, when you will be seeing the recording, again, you go back. I have really taught you that this is the connective tissue, what you are seeing here, right? Now, as you keep on moving, you will see here that there is an increase in the size of it, right? How it is increasing, right? And now if you see this grade, it has just bulged. Means if it is an excessive synovial hypertrophy, means the highest grade, then you will be having the bulging up of the capsule, right? And if you correlate it with Doppler, okay, this we are correlating because there is a synovial hypertrophy. It might not be the active one, right? So when I say synovitis, make it clear. When I say synovitis means I should have a synovial hypertrophy and my color Doppler activity should be there. So I am going to call it as synovitis. So this is just a simple synovial hypertrophy. My color Doppler is not taking up there, right? But if I see this condition, my color Doppler few it is taking up, means it is synovitis, okay, not only the hypertrophy. Then if you see the slides, it is almost more than that, right? And if you see the last one, it is this much. So this patient is going to have IA, okay, here. So you can just say to your, rheumatologist that this, please evaluate it further, because I send all my patients to my rheumatologist friend because I think he is better in rheumatology, starting with the biologicals and all. So I usually send my patient if I happen to see something like that when I'm scanning. Okay. So this is very important for you to understand the synovial hypertrophy, and all synovial hypertrophy need not be having an color Doppler active, activity positive. If they are having an activity positive, it is synovitis which we are seeing. And that is an acute inflammation. And when you are seeing the head, which I have shown you, so this is the head and this is the cartilage, that is the capsule, right? When you just see this, so this is the head. Now you see there is a thinning, focal area of thinning. There are irregularities, okay? And there is an absolute loss of cartilage. So these four things also should be there in your mind, because cartilage thickness, thinning of the cartilage, irregularities, erosions, synovial hypertrophy, and your color Doppler activity, they are all suggestive of your inflammatory arthropathy, which maybe, the patient is suffering from. What is erosion? So if this is a bone, there is a depression here, right? So this is erosion. This is how you identify the erosion in the longitudinal axis, and this is how you identify the erosion in the short axis. How did we see the metacarpal head? It was something like this. But if this head is having something depressed here, that is erosion. So when you are scanning I always say that just don't scan because you have to put a needle. You can even diagnose so many conditions and you can really, help the individuals. And if you think you're not able to treat it, we can always refer the patients, right? So that was about the, yeah, that's all. And that was about the erosions, the cartilage thinning, the synovial hypertrophy, color Doppler activity. So what you are supposed to see when you are scanning a joint, just see that joint should be looking hyperechoic, right? That joint, that bone should be looking hyperechoic to you, right? But in the bone, if you are seeing the erosions, yes, again, you have a category for the erosions, grade 1, grade 2, okay, depending on the size of the erosions. So you see the erosions when you are looking at the bone. Then when you are looking at the joint, you should see whether there is any synovial hypertrophy or not. If there is a synovial hypertrophy, what exactly is the grade? How can you assess the grade? Just look at that slide and just remember it. It will be like that, okay? So if there is a diffuse synovial hypertrophy, just pulling the joint completely, then in all the cases, even if you would have seen the hip joint, right? The capsule they would have shown you. So if the capsule is just becoming convex, okay, usually it is concave like this, but if it is becoming convex, that itself is a sign that you are dealing with a patient who is having synovial hypertrophy, right? If your hypertrophy is taking up the color Doppler, it is synovitis. So whenever you are looking at a joint, just complete this, write it down in a paper just next to you that you have to look for it. Then over the joint, you are going to have the tendons. So look at the tendon, whether the tendon is present there or not. Once you have finished looking at the tendon, you are able to find the tendon where it has to be, right? Then follow it to your metacarpal, look for it, whether it is there or not, right? Then you should look for the ligaments. These are the few ligaments which I have taught you. There are ample amount of ligaments. There are almost some 20, 25 ligaments which are there, right? But still learn the common ones first, right? So if there is a ligament injury, you can very well find it out with ultrasound, at least these ligaments, because they are very nicely visible. Fine. So just try to find out whether there is any kind of ligamentous injury. Tendon, try to look whether there is tenosynovitis of the tendon, because in the hands, it is more of your inflammatory arthropathies, which are common, and especially the RA. So you should know how to look for your DRUJ, how to look for your ECU. That is very, very important. Your metacarpophalangeal joint and your PIPs. This you should never miss when you are scanning your hand. Very important. Very, very important. So that much only for today. And if you have now any question, you can ask me, or you can enjoy your Saturday night.
I was watching you last week I was in Delhi. Now I'm back to Zimbabwe.
You are back
Yes, I'm back. I was in Delhi then. Last week I was in the whole month. The
last
whole
week.
month I was in Delhi. It was a bit hectic. The timing here, 3.5 hours to adjust with the daily time. I'm back now to the normal time back.
Okay, no problem. You watch the recording, because see, hand, you usually hand and all na, in any of the courses across India, I'm just talking about, nobody teaches so much in hand. This is a very important, I should say, an area, and which is, under scanned, I should say. So you watch the recording, and if you have any problem, we are always there to help you out. Okay. But scan, because this is important. If supposedly during the course, if you find, if you are scanning, if you're finding any kind of difficulty, you can ask us in the next class. We can demonstrate you again. You got my point? So that at least you are clearing up your doubts. So keep on scanning in the same week, whatever we have taught you, so that if you are encountering any difficulty, like how I have taught you about the radio lunode tricuteral ligament, you try to angulate your probe. If it comes in once, it is fine. You try my technique, which I have taught you. Put a finger over the lunate, try to put your probe like that. So keep on scanning. And if again, after that, if also you are finding any kind of difficulty, you let us know so that we can show you in the next class. Okay.
Thank you so much for patience.
Oh, I am very patient. Don't worry. At least with my students, because I know you all are here to learn. So it becomes
you.
my responsibility to teach you. Okay, then enjoy your Saturday, and I'll be posting the study materials tomorrow. Go through them, and if you have any difficulty, ask me in the next class. Okay, till then, take care. Bye bye. Good night.
Good night.
Bye-bye.